So welcome everyone to this seminar on pragmatism and innovation, collecting data in fragile situations during COVID-19. We're just on the hour, but I'm going to give participants a couple of minutes to join. We'll be starting shortly, and we'll be going through a few housekeeping details for the meeting. So thank you for joining us, and we will be back with you in the next couple of minutes to formally begin. Okay, I think we will begin. It's a great to welcome you all for this webinar on pragmatism and innovation. We're just going to begin with a few housekeeping details for the webinar. So if you take us to the next slide. We're just going to ask you to mute yourselves during the main presentations. We'll have opportunity potentially to present to discuss later on. We just want to let you know that this is being recorded, and we're all simultaneously live streaming on YouTube. There are two ways that we are keen to interact with yourselves. One is through the chat box. We're very happy for you to, from now, just introduce yourselves. And we're very happy for you to use the chat function as we go through the presentation more generally, just to make comments and to feel that you can contribute. And I will, as chair, come to some of those later and pick up on them. There's also going to be the opportunity for using the Q&A function to more formally ask questions. So between chat box and Q&A, we want you to feel very much active participants in the webinar. And on the Q&A function, you'll have the opportunity to vote, just to remark on particular questions that you particularly want to be covered in the Q&A, and so we'll be guiding those towards speakers. It's really a great pleasure to be seeing the opportunity to introduce the number of speakers we have listed there. I'll come to them in just a moment. The format for the webinar is that we'll be speaking across a range of studies. Really delighted that we're addressing this very practical issue. There is a significant need for methodologies to collect reliable data in fragile settings at all times. It's a particularly important set of contexts in terms of both eliminating poverty and particularly addressing excess burden of disease, but often particularly difficult to collect reliable and effective data to govern and influence policy and practice. And clearly COVID has made the challenge of collecting reliable data in such circumstances even more difficult. So it's a real opportunity today to share across a number of global health research teams their current experiences of collecting data in those circumstances, recent experiences, and to be able to reflect how we might strengthen our capacities for collecting data in such situations. So we'll be going across 5 brief presentations from those groups. So I'll introduce them in a second. We'll then have a similar length of time for Q&A, for discussion, and then we'll just go around the team at the end just to have their final reflections from them, so we maximize what we're learning from them. I'll do introductions now. You can see on the screen. I just want to give a little bit more detail. Delighted to have Parveen Parmar with us. Parveen is the Chief of Division of of the Global Emergency Medicine Department at the University of Southern California Keck School of Medicine, where she's an associate professor of clinical emergency medicine. And along with her presenting will be Ruwan Ratnayake, who is a field epidemiologist and PhD candidate working on cholera epidemiology and mathematical modeling of the London School of Hygiene and Tropical Medicine. Then we will have Aya Nubani, who is in the Research on Health in Situations of Fragility project coordinator at the Global Health Institute at the American University of Beirut, and a colleague of ours at Queen Margaret here in Edinburgh. We will then have a presentation from Roxana Muller-Friose, who is a humanitarian research and policy professional working in a current role as intersectoral assessment specialist at Impact Initiatives. Then Zila Zesse will address us. He's the Liberian Country Program Manager for Redress, a research collaboration between the Liberian Ministry of Health and 6 partners, including QM here in Scotland and Liverpool School of Tropical Medicine. Then our final presentation will come from Kelly O'Loughlin, and Kelly's Assistant Professor of Emergency Medicine and Global Health at the University of Washington in Seattle in the US, along with Timothy Mwangwe, who is a public health and infectious disease specialist and the head of programs at Makerere University Infectious Diseases Institute in Kasangati, Uganda. So it's a real delight. We've got a lot of presenters, a lot of deep experience in terms of current engagement. And the format we have is very brief presentations, but to introduce their work and key lessons from it. And so we'll have the next slide, please, and I'll pass over to Parveen and Ruwan.
Thanks, everybody. I hope you can hear me. I'll be presenting on behalf of the research team from the International Rescue Committee, and Dr. Parveen Parmar is also on the call from University of Southern California, and also presenting on behalf of the School of Nursing at the Jordan University of Science and Technology. So our study actually started in 2018, and it focuses on the impact of a community health program on the management of hypertension and diabetes among Syrian refugees in northern Jordan. By the end of 2019, we had concluded a household survey to assess prevalence of these non-communicable diseases, and we'd done a causal loop analysis to aid in the development of a new community health intervention for NCDs. So I'll send some of these links to those studies in the chat as well. There you go. So we started the third component, which was a longitudinal step wedge observational study. In January 2020. However, in view of COVID-19, we changed the research question and study design to address the pressing need of the day, which was that primary health clinics run by NGOs were on pause, and there was a curfew keeping patients at home, potentially cut off from their medications. And so we therefore aim to implement and evaluate a remote management strategy for hypertension and diabetes among Syrian refugees, this time using a cohort study. For the remote intervention, medications are delivered to patient neighborhoods, and community health volunteers monitor patients for adherence, complications, and urgent issues, as well as symptoms compatible with COVID-19. The data collection method, we had to change it from in-person household visits by dedicated data collectors to the telephone calls that were made between community health volunteers and their patients, community health volunteers would now conduct both the intervention and the data collection. Qualitative research will also be done remotely and will follow as part of a process evaluation of the intervention itself. So now, just to cover some of the strategies which worked for us in quickly setting up the data collection during COVID-19. So in terms of preparation, we had already focused on training and resourcing community health volunteers with electronic data collection using the ComCare application to track patient progress outside of the clinic. And this allowed us to support them to collect other data using the same interface. And the interface helped us to do training, to add new components like COVID symptom screening, and also to quickly analyze the completeness of the responses as the data was being collected. Second, we really did simplify the data collection process greatly. This meant minimizing the time taken on phone calls with patients to around 15 minutes to save their time as well. We also aimed to ensure interoperability with the existing health information system, which was used to collect relevant clinical data by nurses who provided the initial phone consult to sort out medications and so forth with the patient. So overall, we were trying to collect the minimum study data through these phone calls between the volunteers and patients and leave more time for their intervention, their counseling, their monitoring with the patients during these 15-minute phone calls that were done monthly. Finally, we considered that the change from in-person to phone-based data collection would affect validity in different ways. We wanted to ensure that reaching patients by phone would not affect representativeness, given that in most crisis settings, communities typically don't have universal access to a phone. So this required us to make an extra step of mapping patients to working phone numbers before we started data collection. And it was probably uniquely shown to be possible in this urban setting. And finally, we made a commitment to really pilot the data collection tools first and to do some course correction initially, because we know that asking questions over the phone is very different than doing that face-to-face. So thank you. I'll turn it over to my next colleagues.
Thanks, Roy. Aya, over to you.
Hello, everyone. Sending greetings from Lebanon. So I'm going to present or to give a brief overview of our study on behalf of the ROOF research team at the Global Health Institute, AUB, and at the Institute for Global Health and Development at Queen Margaret University. So it's the study started when COVID started in March 2020, and the study entitled Health Systems, Stressors and Coping Mechanisms During COVID-19. It's a multi-country study, but we're gonna focus on the case of Lebanon. So the main aim of the study is to explore how the community members and the primary healthcare workers are, in the context of the COVID-19, are facing several challenges and stressors on different levels and in contrasting economic and fragile settings. So we decided to select two settings that mainly Beirut, which is the urban city in Lebanon, and having lower poverty rates when compared to the rural areas in the Bekaa region that host the highest percentage of Syrian refugees. And we adopted mixed methods study designs, which entails and includes longitudinal quantitative surveys and a new participatory qualitative approach, which is the photo voice method. We designed an online web application, a bespoke application, and we called it Co-Voices in order to collect this primary data. And we are supplementing this data with semi-structured interviews. So our main target population was community members, including the Lebanese and Syrian refugees residing in Beirut and Bekaa, and primary healthcare workers at selected primary healthcare centers in these two regions, with health officials that are being included in the pandemic response in Lebanon. So what's innovative about our methods and approaches? Definitely first during the critical time of COVID and mainly during the critical time of political instability and safety issues in Lebanon. So it's a remote online application where we are ensuring the safety of our participants and at the same time of the research team. Second, the designed web application includes features that make sure to remind the participants of their weekly task over the 4 weeks. It includes notifications and calendars that the participant is able to download to his mobile phone. And another thing is that the interface of the application allows the participant to take pictures and to reflect on this picture through a short voice note. And the third thing is the new photo voice the approach, which is a new way of allowing the participant to get engaged and reflect on his certain thoughts through taking a picture and explaining it through a voice note. Now, definitely the challenges are many. We are facing challenges at the level of the participants themselves. We are having loss of follow-up and the issue of missing data. Another thing is that during this critical time of COVID-19, we're having, it's being overwhelming for healthcare professionals to be involved in the study. And another thing is that since we are including Syrian refugees, we are automatically removing or excluding those who don't have access to Wi-Fi or smartphones. Other challenges might be related to the use of the mobile application or the web application, where it's being challenging for those who are from older age groups and from older age groups, and at the same time from lower educational levels, since we are including Syrian refugees. And another thing is that the photo voice approach is being a new concept in the Lebanese context. So people are questioning always what's the point of taking pictures and explaining them. So these are being our major challenges. Now, what we have learned from this study or and this project is that definitely safety always comes first during critical times. We need always to take into consideration the best safety measures for the research team and for the data collector, and at the same time to try to design the best research method that can help us collect the reliable data and at the same time not to overwhelm the participant. Now I'm leaving it for my second colleague to give this.
Thanks, Aya. So I think it's over to Roxana now, I think. Thanks, Aya.
Hi, good afternoon, everyone. Thanks, Alistair. And thank you to the webinar organizers for facilitating the discussion. I hope you can all hear me all right. So our study, which is being conducted in partnership with the University of Manchester's Humanitarian and Conflict Response Institute and the Johns Hopkins Bloomberg School of Public Health, is utilizing household data to understand the impacts of COVID-19 on multi-sectoral humanitarian needs. The data sources for this analysis are multi-sector needs assessments, or MSNAs, which are facilitated in a number of contexts annually by Impact through our initiative called REACH. Each MSNA consists of anywhere from 10 to 16,000 household interviews among all affected population groups in all crisis affected areas. So just given the sheer scope of this data collection exercise, the COVID-19 pandemic has had significant implications for how we implement data collection this year, both in terms of the operational constraints as well as ensuring the health and safety of both the survey respondents and our field teams. So to address these challenges, we first tried to explore and pilot a few innovative approaches. One example in Ukraine, where we were able to access households but wanted to minimize interaction time, we tried to collect phone numbers from randomly selected households and then do the interview itself by phone. We piloted this in the field, but we experienced high non-response rates that made this a bit difficult to operationalize. In other contexts, we also looked into accessing databases of mobile phone numbers through telecoms providers or telecoms ministries. However, the sudden nature of the pandemic, it didn't really leave a lot of time for us to pursue this option because it requires compliance with legal frameworks, especially around data protection and privacy, that could have taken up to a year to finalize. So ultimately, given the critical time pressure of the assessments, we opted for more practical solutions, primarily switching to phone-based methods, even without a clearly defined sampling frame in some of the most hard to reach areas. As well as where we could proceed in person, instituting comprehensive public health and hygiene SOPs that all field teams had to strictly implement. So in terms of the SOPs, this ranged from pretty standard practices like wearing masks, social distancing during interviews, regular hand washing, to some more creative approaches. For example, in Afghanistan, some enumerators were deployed by motorbike rather than in multi-person vehicles. In other contexts, we trained the staff of partner organizations that were already operating in the area to conduct the interviews to minimize the travel of our staff and any associated transmission risks with people moving between districts or moving to areas they weren't actually living in. Even with all of these kinds of approaches, of course, in a public health crisis of this magnitude, there are no perfect solutions. So we had to kind of accept some methodological limitations this year. One example would be with the lack of visual verification for some of our sectoral indicators. For example, identifying shelter type or damage, confirming civil documentation, vaccination cards, etc. They were not being, we wouldn't be able to visually confirm those through a phone-based interview. We also had to consider the length of the interview, which is mentioned by a previous panelist, ensure that the respondents stayed engaged throughout the interview. And perhaps the biggest challenge was the lack of a sampling frame in some of these areas, particularly when we're talking about non-camp settings or in the host community where we didn't have full beneficiary lists or household registration lists to construct the sampling frame. So in these most hard to reach areas, we weren't able to implement probability-based sampling. So findings from the data collected in those areas were often indicative rather than statistically generalizable, which then had implications for the subsequent analysis. I think from these experiences, we can kind of distill 3 key lessons learned, which I'm happy to discuss a bit more also in the Q&A. One is to invest time and resources in training and other preparations with field teams. So thorough, comprehensive training can help ensure that the correct processes and public health protocols are adhered to in very difficult operating environments. 2 is to maintain flexible and adaptable data collection work plans to manage continually changing mobility restrictions, lockdowns, rising cases in hotspot areas, etc. So our teams developed COVID-19 monitoring indicators and thresholds to determine when to switch to remote data collection or when to designate an area as unsafe to access directly. So for example, confirmed cases, death rates or transmission rates that exceeded certain thresholds, and these thresholds were developed jointly with health partners on the ground, were then used to kind of make those determinations. And then thirdly, to prioritize do no harm approaches. So ensuring that the utmost safety of both enumerators and respondents was a guiding principle when designing the data collection methods, even if this had to mean lowering expectations regarding the robustness of data in some hard to reach areas. So I'll stop there. Thanks very much. I'm looking forward to the Q&A.
Thank you so much, Roxana. It's over to Zila.
Hello, everybody. Thank you. Prior to COVID-19 in Liberia, the Liberian Ministry of Health and several of its neglected tropical diseases partners were implementing a research project called Redress, which is aimed at developing an optimal approach for the case management of severe stigmatizing skin diseases, an optimal approach that can be replicated in other countries in Liberia, but also in Africa and beyond. These partners included the Queen Margaret University, University of Liberia, and several other institutions globally. With the onset of COVID-19, which wasn't anticipated, we thought then to move into several other areas of research centered around COVID-19. And one of those pieces is the research on health system stressor and coping mechanisms during COVID-19. A case study of Liberia. This study is similarly occurring in other countries, but in Liberia, we're looking at the Liberian perspective. So our intent is to understand the life experiences of healthcare workers in Liberia as they go through the period of COVID-19 and is the services within their personal lives, their professional lives as well. And with COVID-19 in Liberia, Liberia has 15 political subdivisions, which we refer to as counties. And of those subdivisions, 3 of them are the top infected counties are Monserrado, Maigibi, and Nima counties. So Nima counties and Nima and Maigibi counties were preferred because they have the second and third most infections of COVID. So the impact on health workers can be easily assessed and determined. And we believe lots of lessons could be learned from those counties. So the platform that is established to collect data from these health workers who we are targeting to study consists of cross-sectional longitudinal surveys and as well as photo voice study. So with longitudinal, we are looking at the experiences of healthcare workers repeatedly over a period of time. And an innovative platform that we are using is called the Bespoke platform. It is something that is quite new to the Liberian experience. It is a web-based platform that health workers can access using mobile phones that have internet connectivity. So the health workers will download these bespoke platform. Requires that each health workers will have a set of questions that he or she will answer per day. As part of the data collection process using the bespoke approach, health workers are required to take pictures of their life experiences as well as record short audios explaining what those pictures are about. And as we've been going along, that has been quite an innovative approach to reach health workers in rural and urban environments that are not easily accessible with the limitations in movement that we're experiencing due to the COVID-19 effect on the economy. But while we are implementing this innovative approach, we've come across a few challenges. One of the challenges is that ethically, health workers are supposed to withhold the app with level of confidentiality and should not be sharing the app, neither pictures or audios that they're recording with other persons who the study do not concern. But with open engagements with the healthcare workers, we've realized that with Liberia being a country in which poverty is an issue, literacy is also an issue with only 46% of the population being literate. Several participants are sharing the mobile phones with other relatives or friends to enable them to help them in accessing the app because of their computer limitations. A few of them are using borrowed gadgets, so using gadgets that belong to other people, which are compromising confidentiality as a concern for the study. So these within the amongst the people, the limitations that some of them have with technology, with the limitations that some of them have with not having access to mobile phones, but yet enrolling onto the program. A few lessons were learned over the period, which we'd like to speak of. One is that with the challenges the participants are finding, we realize that while designing such innovative approach in fragile environments like Liberia, environment where poverty is an issue, it is important to have open and continuous engagement with participants using other platforms such as mobile phone calls and daily check-ins. And with these platforms, they have been very helpful in helping to unveil challenges participants have been having. It has been helpful in helping to educate them on how to use the mobile phone applications quite correctly, and that is has been supported in having results coming from the participants as much as possible. Another thing is that we have found it difficult to design a strategy that will prevent people from sharing gadgets or borrowing gadgets. So as a lessons learned was to design safeguarding clauses within the app, reminding and requesting participants to avoid the sharing of the app with people who the study is not concerned, but also with put in clauses to remind them to delete audios and pictures from the mobile phones once those were uploaded, as well as including clauses to safeguard the institution so that when these people should have to share these pictures of phones or share gadgets, then the institution is protected because they are quite aware that they shouldn't be doing breaching these ethical clauses. So thank you. At this point, I'd like to stop, and I'm sure we'll have much more to share during Q&A. Thank you.
Thank you, Zila. So now for our final brief presentation, and it's over to Kelly and Timothy. Thank you.
Dr. Timothy Mwange and I are happy to present to you our study titled Dial COVID, Remote Mitigation Through Telephone Symptom Surveillance in Refugee Settlements in Uganda. And we are conducting this research in collaboration with colleagues from UW Medicine, Makerere University in Uganda, Medical Teams International, Harvard Humanitarian Initiative, and VIAMO. For this study, which is just getting started this year, our goal is to implement a mobile phone-based interactive voice response, telephone surveillance and mitigation tool, which we've titled Dial COVID, to be used among refugees living in Uganda. The second part of our research will be to test and validate a screening algorithm for COVID-19, which is disseminated through the Dial COVID tool. And in doing that aim, we will test 1,000 people for COVID-19 to see if we can come up with a prediction algorithm for who is screening positive. For our third aim, we will assess COVID-19 risk perceptions and knowledge using another interactive voice response survey over the phone. And for the fourth aim, which is a qualitative aim, and also based over the phone, we will be seeking to understand barriers and facilitators to adoption of COVID-19 prevention and control measures. Timothy.
Thank you, Kelly. We're going to do this work in refugee settlements across Uganda with the focus on West Nile region and southwestern regions in Nyashika, looking at the refugee population. Yes, Kelly, do you want to go on?
Well, we are in a different situation from many of our colleagues since we are just starting this year. But we will, though we are early in the process, we have learned some critical lessons already that we want to share with you. The first is a crucial need to design and implement research with local partners, including implementing health partners and collaborators from the local government, especially during a time like a pandemic. The second is the importance of data collection methods that will necessitate minimal participant contact and that are safe and easy to scale.
We have the other thing that we're looking at is having data collection using mobile phones, and these do not have to be smartphones. And we can use IVR, interactive voice response, for data collection within this population.
Thank you.
Thank you.
Thank you, Kelly and Timothy. That's been great. Strong appreciation for our presenters keeping to time. They've done extraordinarily well, given they are all deeply involved in data collection, lots of things to share, but we thought it was most useful if we shared very brief presentations and left plenty of time. We've got just short of half an hour now for questions. Joanne McFadden, thank you. So Joanne had put a comment in the chat, which many of you would have seen, about sampling, particularly issues about gender actors, which I'll perhaps pose in a minute, or encourage others of you to review that there. And Jordan's also posted a question. Just a quick reflection from me while you are posting questions or reflecting on things. I found it really encouraging, first of all, for the honesty of the very real constraints and difficulties. And so I think we've unearthed a lot of real challenges here. We're not trying to gloss over those challenges in any way, and the exacerbating challenges of collecting data in these fragile settings. I think we heard quite a lot around adaptations and flexes to try to accommodate that, a lot of it around mobile technology, and I think it would be interesting to have questions regarding that. I'm particularly interested as we go through this sense to which this is an adaptation to business as normal, to which we will then return, or the extent to which contexts such as this are encouraging us to understand real innovation in data collection. So, for example, the idea of phone contacts, or indeed seeking to minimize length of time with the respondents, whether that becomes something of part of good practice going forward, or whether we just see that as a temporary accommodation because of particular operational concerns. And then latterly, I think there was important ethical issues and also general good practice regarding engagement with local partners, that maybe we're learning some old lessons that are being really reinforced as being particularly crucial at this time. So thank you, presenters, both for illustrating the challenges and the difficulties, but also some of the innovations and some of the promise that's coming forward. I want to come to Jordan's question first. Many of you can see that on the screen, but I will read it out. In fact, Jordan, I'm going to check with Julia. Can you unmute Jordan? Is that possible? Just so Jordan can ask his question live. It's quite nice to see Jordan if that's possible. I don't want to overcomplicate things for our facilitators, but is that possible?
Yep, I've just tried that.
Okay, so Jordan, do you want to, most of us can see your question, but I think it's a really important point about this mixing of interviews and phone interviews. Are you able to speak? Okay, Jordan, I can't hear you, so sorry for just posing the question on your behalf, but as I think you can see, most people can see it on the screen, that for teams that use a mixture of socially distanced face-to-face interviews and phone interviews, in the same locations, any insights into the relative validity of those forms? I won't come to every speaker on every question, but I'll be particularly looking for people to contribute to questions where they think there's a particular thing that they can share. So thanks, Anna and Monica, for your questions. I'll come to you again shortly. Let's broadly start in the order that, so can I come to Ruan and Paveen, just to start with that first question, because I think you were largely collecting data then by remote means, but your confidence in, I think you did actually comment, Ruan, briefly on the validity of that with respect to other forms of data collection. Would you like to come in and reflect a little bit on that?
Sure thing. It's a great question. I think in general, we very much prefer household data collection, face-to-face data collection, and we've done that before in a survey asking very similar questions. We haven't, formally compared to even talk about whether there's differences in validity, but I think some of the main issues are assuring that what you're able to ask by phone is really realistic. Some of the data collection that we wanted to do was around complications of diabetes, for instance. So it would require assessing and recording this the presence of diabetic foot or some sort of complication. So obviously that's much more complicated just over the phone and maybe not possible. So looking at ways to pare down the data collection to assure that questions that can be done succinctly over the phone make sense is good. And just I think leading into the next questions around using photos and videos and so forth, there is scope there to expand and try to increase the validity of information collected over the phone by taking a picture of that sore or something like that. And obviously there's privacy and confidentiality issues as well. But just to think about the way we collect that data and essentially to assess whether things collected by phone should be collected simply face-to-face only. Thank you.
Okay, thanks ever so much, Ruan. I'm going to keep moving across questions. There's more we could talk on that, and we might come back to that. Joanne posed a question that I think most of us can see there, which actually picked up one of the issues that Roxana raised around sampling issues, particularly if we don't have complete phone records. And I think Joanne was reflecting on her experience of telephone surveys largely being unrepresentative in terms of female representation. I think Kelly has put her hand up that she has some reflections on that. So Kelly, can I come to you to reflect a little on Joanna's question?
Thank you. For Dial COVID, We are going to have a dial-in option, so participants can flash the line and then they will receive a callback and be able to participate free of charge. We additionally will have a proportion, a 10% portion probably of the sample that will be random digit dial, so we'll be able to have that comparison. But our collaborators, Viamo, have done a lot of research in this space, and certainly what Joanne points out is very true, that the random digit dial users are quite different than the people who have the opportunity to call in. And we're hoping to overcome that in this way.
Thank you, Kelly. And actually, there's a related point from Clayton Boyink, and I'm going to come to Aya, because Aya, you mentioned trying to make them accessible to different groupings. And sorry, I've now lost that question, but basically around the challenges of making it accessible to other members in terms of underrepresented households. Aya, so what have you experienced that challenge in terms of ensuring this degree of access to households that may not have phones or may not have equipment? And do you think that's very significantly impacted the representatives of your samples?
So yes. So basically, we're encountering this mainly with refugees who are living in tents where maybe a family or two, they only have just one smartphone. But it's not being that major challenge that is affecting our sample size. What we are trying to do is that in parallel to charge for participants through mobile cards or data so that they can have available like 3G to be able to access the link and to be able to collect data further. But it was not a major challenge that's affecting our sample size or the data that is being collected. So we're always trying to find alternative solutions for this.
Okay, thanks, Aya. That's helpful. I'm just juggling a little bit with the function buttons. A couple of people put their hands up to speak, but I actually can't see who they are. So Karen or Julie, if you can, but I'll come to some more questions if you like, but could you see any flagged hands up and do you want to call those people in?
Yeah, I have one from Axel, if you want to go ahead, and you should be able to speak.
Thanks, Karen. I found the function now. Axel, you wanted to come in. It looks like Axel can't get through, so I'll go to one of the other questions, Axel. So if you want to post your question in either the Q&A or the chat, we'll come back to you later. Right, Julia Oguero has a question. Thanks to all of the panelists. Any insights on how these tools methods could be used to assess the needs for assistive products, wheelchair glasses amongst refugees and in fragile settings? I noticed that Anne McKinnon from FCDO, a former colleague, is on the call. Great to have you with us, Anne, and I think recognising particular challenges of accessing populations with disability. And so I'll just ask anyone within our group. I think none of the projects are directly focused at particular vulnerable groups or groups with disability, but I'm interested in terms of the innovation that you've been engaged in, if you see any particular opportunities that have been opened up by the sort of work, the sort of methods that you have been doing. Anyone within the team, I can pick on someone, but anyone within the presenters like to share a little bit on that?
I mean, I can share one comment.
We
work with we work with populations. This project is specifically focused on refugees that are affected by diabetes and high blood pressure. They tend to be elderly, and they certainly do have higher rates of disability. This isn't something we've specifically addressed, although the use of this kind of remote methodology to complement the delivery of clinical care for those that can't make it to clinical settings has certainly been considered. I would say, one of the challenges in using remote methods to assess for the use of assistive devices, wheelchairs, et cetera, would be the lack of ability for an in-person assessment for fitting and actually being able to decide what people need. One of the issues we of course ran into is that our initial intervention involved biological measurements, so measured blood sugar and blood pressure. And I think similarly, we would run into some issues. So I do think it would have to be complemented with a clinical setting that could do these assessments in person, maybe just to identify people that self-identify as having a need, really. That would be my thought.
Okay, thank you very much, Parveen. There's an anonymous attendee. I don't know why you needed to be anonymous. I hope it was just a system failure, but asking a very valuable question about tracking measures of privacy risks or protection. And I think a number of presenters hinted at that. I think, Zila, you particularly addressed it in terms of application sharing, et cetera, and confidentiality. So perhaps I'll start with you, Zila, just to ask if you feel these methods, given that they had created those risks of confidentiality, the extent to which you felt, I think you were talking about do no harm, but able to mitigate and control those risks. So I'll come to you first, Zila, but then anyone else willing to comment on that of clearly wonderful innovation, access, but it does create new challenges for protection and privacy risks. So Zila, your reflections on being able to be on top of monitoring, mapping those sorts of risks.
Okay, so thank you. So one of the things that we did, which was innovative, is to engage participants through daily mobile phone conversations. And they did that. I mean, mobile phone conversations were able to reveal participants who were using mobile gadgets that didn't belong to them personally. And so that was an issue that was able to, a process that was able to help us identify participants who were sharing gadgets with other persons. But one of the safeguarding methods that we employed was to build into the application constant reminders to participants to delete pictures and voices after they have loaded them to the platform. Another thing the app does is that it wants participants to collect consent before uploading pictures that belong to pictures of other persons. And when the photos were uploaded, the app again asks the participant to confirm again that consent was obtained before uploading the pictures to the app. I'm not sure whether I got you quite well, but I think if there's anything I can speak of, please let me know.
Thanks very much, Zila. That's helpful.
Okay.
Now, so I'm going to first of all give a chance for anyone else as the presenters to respond to that. Just shout basically or signal to that to me. Meanwhile, I'm going to go to the chat. So again, we've got about 10-12 minutes left. So there's still room to ask some more questions in the Q&A function, but I'm going to come to the chat bar for a couple of minutes to pick out some things from there and encourage panelists to reflect on that. One thing, a very useful use of the chat is to share experience across, and we are recording this, and it's great to put people into contact with each other. So some useful reinforcing of lessons learned across the participants. There is one comment about after the webinar, which I think we could do this, of basically logging some of the common challenges, just as a distilled list, and some of the solutions as a tool or as a reflection. And I think that would be something that we could very readily put together. That was Idris Rasooli asking for key limitations of available technology and reflecting on how those could be overcome. One of the things Monica raised this point, Monica Bagaya, as adopting to the new norm, how you're addressing technology accessibility. This broader issue, I suppose it's pointing to what I've flagged a little bit about seeing this as not as a temporary adaptation, but maybe a longer term shift into the way of collecting data. I was struck by Rowan's comment initially of course we prefer household surveys. So that the understanding that this is an accommodation. I wondered if I would encourage any panelists to feel little bit picking up the issue I raised earlier, that there are things that they are able to do now, that they're doing now with this technology or with this new approach, that is actually better than before, or has opened eyes to new ways of working that we wouldn't have historically done. So clearly some of this is adaptation and doing as best as we can in difficult circumstances. I wonder if any panelists wanted to pick up on the sense of there's innovation here that you would want to continue with post-COVID, post very acute difficulties in fragile settings, but what you would basically see as emerging good practice. I might jump on. Actually, Roxana, can I come to you with that? Because you touched a little bit on this. Do you see the adaptations as something that might be a permanent innovation, reflecting good practice in data collection, or is it largely accommodating current circumstances and current difficulties?
I'd say largely accommodating and adapting for the context, given our need to kind of conduct face-to-face household surveys. But I will say one of the lessons that I think we should carry on as best practice is working to make household survey tools as short as possible while still collecting the key indicators that we need to avoid assessment fatigue among the population of interest and to ensure that respondents stay engaged during the whole interview. Even when we do face-to-face household surveys, we find that interest in the survey lags towards the end of the questionnaire. So that is a general good practice that we'd like to try and push even when we are able to access households easily again in the future.
Okay, thanks ever so much, Roxana. Quickly, any other panel members? Yeah, on you go.
Yeah, sorry, I couldn't raise my hand, it's not working. I just wanted to talk about the new innovations that are available that we think that will stay on for long, and these include remote consenting, doing consenting process on the phone, and then we see the data collection using the mobile phones and IVR or SMS technology. These are some of the things that we think may go on even post-COVID. The challenge here is having to share gadgets between participants and confidentiality issues that may arise. Thank you.
Okay, thank you, Timothy. I want to reflect on, there's a number of questions in chat really around use of mobile phones, and I saw it's such a long list of participants, I can't quickly find it, but we have a colleague from GSMA on the call, and it would be interesting, I think, if you wanted to just to reflect what power you think is in our increased use of the recognition of data that's held on mobile, connectivity, and that as a source of data that we could be much more effective in our use of in fragile settings, given the evidence of use, although acknowledging the challenges of the distribution of access to mobile telephony in context. So that's just a flag for a colleague from GSMA to come in if you would like to just flag that in chat or Q&A. I'm scanning other chat items. Sorry, Carrie, on you go.
There's one question that came in via YouTube that I'm just wanting to put to panel. In case there were methods where you had your baseline done via traditional method of data collection, but the end line was via a different method, how did you mitigate for that, basically? I'm guessing in analyses or further. I've rephrased slightly to make it shorter. But
thank you, Karen. Can I come to, I think the situation, I think maybe through what Rowan and Parveen, you had some data from pre-COVID. I mean, you've had to bridge that gap, is my assumption from the way you presented, yeah?
Oh, okay, Parveen. Yeah, we had some data from I think the 2 months before COVID really hit, but I mean we still haven't thought about how we're going to use it. I think what it's made us think about a lot is less baselines, but more what is the pre-existing data that we have through other routine systems that could be potentially comparable as we go through. So not necessarily the data that we collected for a different purpose for this study, but perhaps health information system data or monitoring data from other parts of International Rescue Committee's programming that monitors households for education and so forth. Are there elements that would be relevant? I don't know, but we've certainly done a lot of looking. Thank you.
Okay, thanks, Ruan. Can I just come to Paula McLeod? So Paula, it's a point you've made, I think is an important one rather than a question. So if we can and there's a vote for it. So Paula, if we can unmute you, just reflecting on learning coming about international stat systems and mixed mode effects, I think it would be good to share that if you're available to do so. So Paula, do you just want to elaborate a little bit on that point that you've made in the Q&A?
Okay, can you hear me?
I can, Paula. Thank you. Love to hear your voice.
Brilliant. Sorry, tech fear. Yeah, no, it's just such an important point. It's been really useful to listen to all the presentations today, but these questions that are coming through about the mixed mode effect of starting with an in-person survey, finishing in online, the challenges with the way different people perceive, answer and engage with these survey methods. There is a huge amount of learning around this across the entire international stats system. We're all trying to adapt to this and accommodate. So I think it's just really useful to flag that these sorts of challenges, and as you say, bias in access to technology and telephony, be it by gender or income quintile or whatever those barriers are. I think I just wanted to flag that there's a massive community approach around this, and it's really good to make sure that we're linking in with local partners, but also with some of our national stats offices, our big data engines, to just continue to share and build on these learnings. And as you say, mixed mode effects are not particular to fragile states. There's a lot of this going on at the moment. So let's keep sharing and engaging with the learning.
Thanks, Paula. And there may not be, but if there is a sort of a repository or a node where some of that learning is being pulled together, it would be great for you to put it in the chat function or to share or something like that, and we could link it in with some of the summary from the webinar. Time's nearly against us. Thanks so many for excellent questions. I'm going to go swiftly around the group for a final reflection on lessons learned, picking up any of the issues. We really only have 3 or 4 minutes left, so it really will be just 30 seconds or so each. But can I first of all come to Ruan and Parvin? Any final reflections on the discussion and the issues?
I put this in the chat, but I think that, just considering that during a time of crisis, such as COVID, many teams are engaging with populations using phone. And so just to ensure coordination and avoid phone fatigue, because that will obviously really impact your data collection. Okay,
thanks, Parvin. Ruan, anything from you?
Just to add that COVID isn't unique. I mean, we're dealing with populations where we're always expecting there's going to be some sort of cutoff from conflict or disaster or something else. So I think it's been a good exercise to think through these different methods for collecting data when they get disrupted. Thanks.
Okay, thanks, Ruan. Aya, your final thought.
Yeah. Yes, so also I'm going to say that it's definitely challenging to collect data during critical times of COVID and other safety and security issues, but definitely we should always take into consideration the target population that we are studying and tailor our mobile or web applications to things that fit the characteristics of this population.
Okay, thank you, Aya. Roxana, can I come to you?
Sure. To kind of echo some of the points of the other panelists, I think a reliance on phone-based and mobile methods is, of course, important in a situation like what we're encountering now, but also to look for creative ways to access hard-to-reach parts of the population and maybe complementary data collection methods that are not necessarily household surveys, but more qualitative in nature, so that we have at least a baseline of information in some of these harder-to-access areas.
Thanks, Roxana. Zila, can I come to you? Final thought.
Yeah, thank you. So with COVID-19 and the use of mobile applications, is proven to be a preferred method to engage people, especially involved with longitudinal studies. But it's also good to highlight that it's important to make sure that such information being collected are not very intrusive, and subjects being discussed are not very personal or not very sensitive. But also these studies, if they are time limited, so that they are not overwhelming participants who are engaged in the studies. And I think these new phone-based, web-based approaches are quite innovative and a good option for the time.
Thank you so much, Seela. Kelly, and then Timothy, and then we're wrapping up.
Thank you. If effective, interactive voice response telephone surveillance systems can be used not just for COVID-19, but other infectious diseases. And so I think it will be very informative moving forward.
Thanks, Kelly. Timothy.
Yeah, integrating the use of mobile technology in data collection is something that we can have and manage. However, we need to think of ways to mitigate loss of confidentiality among these populations, and also to emphasize or look at ways of letting people know that this is a new innovation, so they can pick up the innovation. Thank you.
Okay, thanks ever so much, Timothy. And again, thanks many people for really very substantive posts in the chat. Thanks for the reflections, Jenny Caswell, regarding GSMA, Mobile for Health. I think really important things there. And I really appreciated Siobhan Green's comment towards the end about knowing the limits of remote data and setting expectations may seem obvious, but it is crucial. And I think that idea of, yes, using innovative methods, using flexible methods, but recognizing the limitations of the adaptations and on the quality of data that we can collect. It's 1 minute past the hour. I have exceeded our limit and people will be needing to leave. Thank you so much to Elra for working with us here in the Research Unit on Health and Fragility to put this seminar together. Thank you so much for our presenters to present so concisely but informatively in the way they've done. And thank you so much for participants for such engaged comments and questions. I'm sorry that we've not been able to cover them all, but reflecting one of the comments, I think we'll be able to consolidate some of the reflections and circulate that around. So thank you all again, and look forward to greeting you at other seminars of a similar ilk. Thank you for your time, much appreciated.